Hello everyone, very glad to meet you here. I'm Liu Xiaodan, a nephrology from the first affiliated hospital of China Medical University. This part, we will talk about the concept of acute kidney injury, AKI. Before we talk about AKI, let's recognize the kidney. This gentleman had described the kidney like this. The kidneys are so beautifully organized. They do their work of regulation with such a positively divine precision, such knowledge and wisdom, that there's no reason whoever he is should be ashamed to own a pyre. This is a beautiful description of the organ that us nephrologists think about every day. Histologically, the kidney is composed of a basic structure and functional unit known as a nephron. Each human kidney contains approximately 1 million nephrons. Each nephron is composed of two major components: a filtering element that consists of an enclosed capillary network and its attached tubule. So the kidney carry out the crucial task of filtering body waste, removing excess fluid, regulating acid-base balance, and maintaining electrolyte levels in the blood. Malfunction of the kidneys could lead to accumulation of waste products, fluids, and electrolytes in the body, which could gravely endanger life. AKI is a concept that describes the sharp decline in kidney function caused by different causes. The incidence of AKI varies between developed and developing countries. In developed countries, AKI is more common in critically ill patients. However, in developing countries, the disease occurs most frequently in young, previously healthy individuals, or in the context of one predisposing disease. So it's important to understand the causes of AKI and prevent them from happening. And we'll talk about it in another video. Before we talk about the concept of AKI, I would like to share with you the naming process of AKI. Because of the naming process reflects the people's understanding of this disease. It's a long story. Here we go. At the beginning of the 20th century, ARF, acute renal failure, was used to describe the consequence of toxic agents, burns, trauma, and operations on the kidneys. Next, during the First World War, the syndrome then was named war nephritis. The syndrome was forgotten until a classical paper about crush syndrome was published during the Second World War. This time, because of histological evidence for necrosis of renal tubules, acute tubular necrosis, ATN, was used to describe this clinical entity. For many years in clinical practice, the terms ATN and ARF were used interchangeably. As a consequence, there was no consensus on the diagnostic criteria, resulting in multiple different definitions. This made a major obstacle to the comparison of different studies and affected the understanding of the disease. So there's an urgent need for a unified concept to describe the disease. The other thing people noticed was both ATN and ARF emphasized the most severe acute reduction in kidney function. However, evidence suggested that even relatively mild injury of kidney function is a predictor of serious clinical consequences. So in 2004, ARF was redefined as RIFLE, risk, injury, failure, loss, end-stage kidney disease. The importance of RIFLE criteria is that they move beyond ARF. It includes patients without actual damage to the kidney, but with functional impairment relatively to physiologic demand. It expands the scope of the disease and helps to get the diagnosis earlier, which is very important for the patients. In 2007, the Acute Kidney Injury Network Group, AKIN, proposed a modified version of the RIFLE criteria, which aimed to improve the sensitivity of the diagnostic criteria. In 2012, based on the previous two classifications, finally, the unified concept and the latest classification of AKI was proposed by KDIGO, Kidney Disease Improving Global Outcomes. AKI is defined as an abrupt decrease in kidney function, which emphasizes both injury, structural damage, and impairment, loss of the function. The current diagnostic approach of AKI is based on an acute decrease of glomerular filtration rate, GFR, as reflected by an acute rise in serum creatinine levels and/or a decline in urine output over a given time interval. Specific indicators are shown in this table. AKI is diagnosed by an absolute increase in serum creatinine at least 0.3 milligram per deciliter within 38 hours, or by a 50% increase in serum creatinine from baseline within 7 days, or a urine volume of less than 0.5 milliliter per kilogram per hour for at least 6 hours. Clinically, we need to distinguish between AKI and CKD. Ultrasonographic evidence of small scarred kidneys is consistent with CKD. What we should know is that CKD caused by diabetic nephropathy, infiltrative disorders such as amyloidosis or polycystic kidney disease can be present with normal or increased kidney size. The other findings of anemia, hyperparathyroidism would suggest CKD. Patients with CKD are at high risk for the development of episodes of AKI. So we must pay attention to the situation of AKI superimposed on CKD. Since AKI is reversible if earlier diagnosis and the treatment takes place, and we'd better know the prior serum creatinine concentrations than to determine the degree of potentially reversible AKI. Okay, this is the concept of AKI. Thank you for listening. See you next time.